My talk is on how to stay smart in terms of radiation dose management in neurointervention, Assam Medical Center experience. These are the list of my past and current collaborators on this issue on daily practice basis. This is a case of dural AVF. After 2 separate procedures, we could manage this complex lesion. However, the patient complained of regional hair loss on 1 month follow-up at the outpatient clinic. From this case, I started to pay attention to the amount of total radiation dose I spent for the procedure and diagnostic imaging as well. I think applying the X-ray is quite similar to spending money as cash. Isn't it a good allegory? Then how to begin? As this webpage, Image Wisely, operated by multiple societies in the North America, they say a pledge to manage the dose could help reduce the dose. When it comes to radiation dose and image quality, the first thing we have to do is being accustomed to some units, especially of radiation quantity. Please refer to Dr. Sproul's webpage for detailed information. For actual irradiated and observed dose quantitation, we should use the concept of effective dose. However, to obtain and calculate that way is not practical in our daily practice. The most practical approach is measuring the surface entrance dose as a surrogate indicator. Air karma stands for kinetic energy released per unit mass of air is good indicator of dose delivered to a certain point, for example, eyelids, thyroid gland, etc. The concept of dose area product DAP includes exposed area. Its SI unit is gray square centimeters and is a good indicator of the total radiation energy delivered to a patient. Please be aware that the unit of Siemens machine is microgray square meter, and for Philips, milligray square centimeters. Since we can measure the dose simply with AK, air karma, and the DAP, dose area product, we are now able to manage the radiation dose. There could be a length list to consider. Let's look into some of the basic points from the patient size to the entrance dose one by one. The first issue is the patient size, thickness of the patient. We have no choice with the size of the patient. However, there still is a room for further consideration, which is image angulation. It is said that the dose would be doubled in every 3 centimeter increase of the target thickness. When you have a choice of one plane, then choosing the thinner plane will help decrease the dose. Another much important point is the angulation issue. Since our body is not round, mostly elliptical like this, with an angulation of the C-arm like this, that may increase the dose significantly by the increase of the traversing thickness like this. Sometimes double, sometimes triple. Furthermore, the image quality would be severely influenced by the angulation. So, we focused on the routine angulation. We thought that Townes' view requiring Some craniocaudal angulation may increase the dose because of the angulation. For our routine PA view and the Townes view, the image thickness of the skull will be thicker with the craniocaudal angulation like this. We reported our experimental result on this issue last year. We obtained a radiography while applying various cranial and caudal angulation with applying various thickness of the copper filters. We found a U-shaped radiation dose distribution. In this angle range, which we usually apply for the frontal angiography, we could see significant increase in dose compared to this PA projection. Both Air Karma and DAP in our clinical practice too. The situation of much more steep increase of the dose is common when we find a good working projection in certain aneurysms, such as anterior communicating artery origin aneurysms, which sometimes require very steep angulation. We need to balance anatomic demonstration and the patient thickness for proper working projection determination. The next issue is image magnification, image zooming. We know the zoom dose factors. The Air Karma has an inverse relationship with the FOV size. The dose will double or triple with the further zooming. In addition to the increase in dose, another disadvantage of magnified image is its limited field of coverage. We can see the target better, but our blind region becomes bigger. Recently available large-scale monitor will allow us digitally magnified images like this, and I believe this is a good solution for the operators with the senile presbyopia. Together with the routine 2D angiographic imaging, another huge source of radiation burden is 3D angiography. We cannot deny the outstanding role of the new technology in our profession. I'm very happy with these 3D fusion images. However, every time I'm obtaining these multiple 3D acquisitions, it often gives me a kind of guilty feeling because the radiation burden seems quite heavy, requiring our attention. That's why active collimation of the field is important. Unfortunately, the XY plane collimation is not available yet for the 3D angiography. Anyway, do we still need a routine 3D angiography for every cerebral aneurysms like this? Why not acquiring with the various acquisition conditions? So we went and tried to see the details of radiation dose setting for 3D angiography, and we found that we can change the entrance dose from 0.36 to 0.10 or even down to 0.08 with or without copper filters. Furthermore, when we pursue various schemes of dose reduction like this, and of course we could note dose reduction down to 70% of the regular dose, like this, without significant subjective compromise in image quality. We tend to obtain 3D angiography with a subtraction mode. However, we need to reconsider its usefulness. We can get different modality image fusion instead. Virtual subtraction would be the way we should go. Since about 1/3 of the radiation burden comes from fluoroscopy, we need to be smart with this job. Needless to say, the dose decreases significantly with less pulse rate. My preferred pulse rate is 7.5 pulses. However, I'm still comfortable with the 4 pulses for the monitoring of the Onyx cast. Don't forget the dose saving from this is significant since the injection duration lasts longer than 30 minutes in most of the AVM and dural AVF cases. Although biplane fluoroscopy is available, we seldom use it. We prefer lateral fluoroscopy due to the anatomic nature of less overlapping. That is also better in terms of the radiation dose, lateral projection. This is a typical case of onyx embolization for the brain AVM. The dose summary chart says air karma from the fluoroscopy per minute is significantly lower on lateral projection compared to the frontal projection. Then how about the neck? In carotid stenting, we also prefer lateral projection. However, when you calculate the dose from the lateral projection is much higher. That is due to the overlapped shoulder density. A little bit of angulation here will help improve this problem. Once again, to the onyx case, this time the embolization was done as the second session. Surprisingly, we found the dose from the lateral view is higher this time compared to frontal, even though the initial dose rate was like this. Why? As we report this observation of increase in fluoro dose in successive sessions of multi-stage onyx embolization, we found that the fluoroscopic dose rate increases significantly as the session number increases. That was due to the presence of radiodense onyx cast from the previous embolization. To avoid or minimize of this problem, we need to be smart with the choice of the measuring field. Choose the measuring field scheme to avoid unwanted region like this. You can choose it both frontal and lateral views like this. The last remedy we can choose is a reduction of the entrance dose to pursue ultra-low dose. Before we directly go into ultra-low dose setting, we went and checked the feasibility of low, very low, or ultra-low doses in cerebral angiography with a phantom. This is a phantom we developed, even though it looks like a funny concrete pipe. Actually, it was made of a material having the same radial density of the skull. After setting a closed circuit, we could inject contrast media, and the radiography was obtained like this, measured the density like this. On our angiography machine, available detect entrance dose settings ranged from 3.6 to 0.08 microgray per frame. DSA images were obtained with these settings with the standard image processing protocol, and then repeat DSA images were obtained with improved image processing protocol with and without copper filters. As a result, the DAP dramatically decreased from 1.82 to 0.08 microgray, and a further reduction by applying copper filter, amazing reduction of the numbers from 8 to 20 in terms of DAP. Needless to say, the SNL and the CNL decreases with a reduced dose. However, we could compensate them by applying improved image processing protocols, even with the cases with the copper filters. Interestingly, we asked the 5 angiographers for their perception of each image quality, whether the quality is acceptable for initial diagnostic photos of unruptured aneurysms. Acceptable result with a yellow color were seen when we applied entrance doses of higher than 0.24 micrograph per frame, the yellow ones. As the conclusion, we found that entrance dose can be reduced down to 15 to 30% of current setting, especially for the aneurysm study. This pair of images is from the same patient with left lateral sinus dural AVF, right ICA with standard dose, 1.82 micrograph per frame, left ICA with a reduced dose of 0.54 micrograph per frame. A little bit grainy here. For the first clinical application of low-dose DSA, we thought that dural AVF embolization could be a good indication. So we started to apply low-dose DSA since 2016. We selected the historical control from 2014. Low-dose setting meant any application of low-dose setting. See this case, and the images were obtained within the same session, conventional and low dose. You can check out grainy and the noisy image here. However, the image was obtained with just 1/3 of the conventional dose, just 1/3. We found this is enough as a control angiogram to see the embolization status. Needless to say, significant DSA dose reduction was achieved. However, total dose reduction was just 1/3. That was because other sources, which was fluoroscopy, remained the same. So we tried to see whether we can reduce the dose with a low dose fluoroscopy. This is the available fluoroscopic dose setting from the usual 23 nanogray down to 6 nanogray. For roadmaps, it requires additional doses. This is a video clip of fluoroscopy and roadmap images obtained with the 8 nanogray protocol. A little bit grainy, but acceptable for angiography examination. Interestingly, most of the operators could not aware of this low dose setting before they were informed. We conducted for 2 weeks of clinical feasibility study. We analyzed total fluoro dose and the procedure outcome. We could cut the dose about half without any procedural limitation or problem. And of course, there are many more points to consider. First, we need to understand our machine better, pursue individual patient-specific approach, team approach, consider using higher concentration iodine contrast media, adopting AI technology for dose reduction and image quality control purpose, and many more. I would like to conclude my talk with this slide. For the radiation dose management in neurointervention, it is not that difficult to begin having a smart attitude. What is important is to pledge to the mission together with your team. During the procedure, please use X-ray exactly like a cash as you are doing in your real life as a reasonable consumer. And lastly, always try to stay creative and try to share your experience and what you have learned with that trial with us. Thank you for your attention.